Imagine a world without antiseptics, anesthetics, or even basic knowledge of human anatomy, yet one in which bloodletting, trepanation, and radical excisions were prescribed as cures for everything from headaches to possession by demons. Welcome to medieval Europe's operating theater, where the line between surgeon and butcher was often blurred, and the promise of relief lurked alongside the risk of a more gruesome fate than the original ailment. In the 12th and 13th centuries, Western medicine drew heavily on Galen's ancient teachings and the Arabic translations of Hippocratic texts. Physicians believed that disease stemmed from imbalances among the four bodily humors: blood, phlegm, yellow bile, and black bile, and sought to restore equilibrium by evacuating excess blood or releasing spirits trapped within the skull. Yet these remedies, applied without anesthesia or sterilization, inflicted trauma that frequently outpaced the patient's initial complaint. Take trepanation, for instance, the practice of drilling or scraping a hole into the cranium. Medieval surgeons thought it could cure epilepsy, migraines, mental illness, and even demonic possession. Instruments varied from primitive bow drills to tree-fine saws with serrated edges, and the procedure often took place under the bare light of a candle, without any form of pain management beyond a swig of wine. Patients writhed, bled profusely, and risked skull fractures, brain injury, or fatal infection. Yet the practice persisted for centuries because occasional survivors seemed to report relief, fueling the belief in its efficacy. Bloodletting, arguably the most ubiquitous cure, involved cutting a vein, often in the forearm or neck, to drain several ounces of blood. Leeches, too, were prized for their ability to suck blood gently. By the 14th century, royal courts maintained vast leech farms to supply noblemen suffering from fever or gout. In truth, patients already weakened by malnutrition or plague often grew more debilitated after losing precious red corpuscles. But since illness itself was thought to arise from too much or too impure blood, the spectacle of scarlet streams convinced both doctor and patient that progress was being made. Then there were more extreme measures like tongue removal for supposed speaking of heresy, or cauterization of wounds with glowing irons to ward off spiritual contagion. Catgut sutures were unknown. Wounds were packed with cloth and herbs, left to heal by secondary intention. Pus, symbolically bad humors, was welcomed as proof of the body expelling toxins. Yet, in many cases, patients succumbed not to their original malady, be it fever or head trauma, but to the surgeon's knife. To illustrate just how dire the situation could be, let us follow the case of Lady Matilda of Northumbria, a 14th-century noblewoman struck by an unrelenting migraine. Records from her convent chronicle that, after weeks of herbal poultices and prayers, her headache persisted. A local barber, surgeon whose apprenticeship had lasted mere months, was summoned. He performed a crude trepanation using a hand-drilled bit, confident that releasing harmful vapors from her skull would restore clarity. Matilda's screams echoed through the halls as the bit pierced her skull. Though the surgeon managed to remove a bone chip, the wound quickly festered. Within days, Lady Matilda exhibited high fever, delirium, and died. Her original headache, replaced by sepsis, spawned in the very moment meant to cure it. Yet for every Matilda, there were patients who emerged from the surgeon's tent alive. Their survival became living proof that these brutal methods could work. Stories circulated of peasants and nobles alike testifying to the miracle of restored health. Such anecdotes emboldened more practitioners to imitate the procedure, even as mortality rates soared. By the late Middle Ages, university-trained physicians began to challenge barber-surgeon guilds, calling for stricter regulation. Anatomy theaters sprang up in cities like Bologna and Padua, where professors dissected cadavers to learn true physiology. Slowly, empirical observation began to supplant dogma. But the grand experiments of trepanation and bloodletting persisted into the Renaissance, underscoring how deeply entrenched these practices were in the medieval medical mindset. Our story picks up in 1423 on the sun-baked island of Sicily, where Sir Antonio de Vola, the celebrated knight of Palermo, fell from his horse during a tournament. The blow to his head caused persistent cognitive lapses, memory loss, and violent mood swings. Local healers tried poultices of thistle and a regimen of daily bloodletting, but Sir Antonio grew weaker and more unstable. Finally, the island's leading surgeon, Maestro Lorenzo di Messina, proposed a desperate measure: trepanation. Maestro Lorenzo was trained in Naples, exposed to the latest Arabic-influenced surgical texts, and carried a reputation for boldness. On a sweltering June morning, he laid Antonio on a linen-draped table beneath a timber canopy. The knight, stoic in his armor breastplate, sipped a goblet of wine mixed with opiates, one of the few pain-relieving concoctions known at the time. Lorenzo marked a spot on the skull, sterilized the area with heated metal, and used his steeled auger to bore into the bone. As the bit scraped through the outer table, Antonio's grip on the table tightened. With a final turn, the auger burst through. Lorenzo pried out the circular bone fragment and glimpsed the pulsating dura. According to Lorenzo's own later account, Antonio's vitals held, his pulse steadied, and the knight whispered, "I feel clearer," yet the triumph proved fleeting. Over the next 48 hours, Antonio developed raging fever and wound swelling. Herrera, a contemporary scholar, attributes this to the lack of asepsis. The surgeon's hands, the instrument, and the linens all harbored invisible pathogens. In a rare stroke of fortune, or perhaps divine intervention, Antonio survived the septic crisis. Over the next months, his cognition returned almost wholly, though he bore a permanent dent in his skull. The successful outcome made Maestro Lorenzo a revered figure, and his case study circulated through medical schools as proof that, even in the absence of modern hygiene, surgical intervention might succeed if carefully executed. Contrast this with the fate of Brother Theodore, a 1437 case from a Cistercian monastery in Burgundy. Afflicted by constant stammering thought to be the work of evil spirits, Theodore's abbot allowed a ritualized trepanation within the churchyard. No anesthetic or wine was provided. The novice lay on the bare earth as the monk surgeon hacked into his skull with a hastily forged tool. Blood pooled in the trench, and the abbot claimed it was the devil fleeing the throne of the head. Theodore died within hours, and his martyrdom was catalogued in the abbey's necrology as proof of piety and the peril of unskilled hands. These two stories exemplify the razor's edge between cure and catastrophe. They also highlight a critical factor: the surgeon's training. Barber surgeons, whose guilds spanned towns and rural villages, learned through apprenticeship, observing a handful of operations before wielding the knife themselves. University-educated physicians studied theory and anatomy but rarely set foot in an operating room, delegating incisions to their more hands-on counterparts. This division of labor meant that a patient's survival often hinged on geography and the happenstance of which practitioner answered the call. Still, innovations did emerge. By the late 15th century, Ambroise Paré in France pioneered ligatures to tie off bleeding vessels rather than cauterizing them, reducing trauma and mortality. Surgeons began experimenting with alcohol-based disinfectants, and Guy de Chauliac's seminal 1363 text, Chirurgia Magna, systematized protocols for surgical techniques, helping to professionalize the field. Yet even these advances arrived centuries before reliable anesthesia or antibiotics, so risk remained astronomical. The legacy of medieval surgery is woven into the very fabric of modern medicine. The gruesome trials and triumphs of pre-anesthetic practitioners set the stage for later breakthroughs and the ethical frameworks that govern patient care. Throughout the 16th and 17th centuries, accounts of trepanation and crude excisions fueled public outrage and academic inquiry alike. Philosophers questioned whether the pain inflicted in the name of healing was ever justified, planting early seeds of informed consent. Hospitals, once seen as mere hospices for the dying, began to establish dedicated surgical wards, seeking to isolate contagion and refine techniques. Surgeons like Paré advocated for gentler methods. Robert Boyle's experiments with pressure pumps in the 1660s hinted at the future of anesthesia. Meanwhile, the macabre fascination with medieval surgery found its way into art and literature. Hans Baldung Green's 1515 woodcut The Extraction of the Stone of Madness depicts a surgeon drilling into a patient's skull to remove insanity, lampooning the practice. Shakespeare references bloodletting in Macbeth, using it as a metaphor for guilt and overindulgence. These cultural echoes reveal how deeply ingrained the fear and curiosity about surgical pain was in the European imagination. Perhaps the most direct lineage from medieval brutality to modern care lies in the evolution of antisepsis. In 1847, Ignaz Semmelweis observed that hand-washing by physicians dramatically reduced puerperal fever deaths, a principle later amplified by Joseph Lister's carbolic acid sprays. Lister's work dismantled centuries of tacit acceptance that infection was an unavoidable consequence of surgery. The grim surgeries of the Middle Ages became cautionary tales lessons in what not to do, yet despite advances, echoes remain. Even today, debates over high-risk operations, brain surgery, heart transplants, experimental gene therapies resonate with the same tension. Does the potential cure justify the peril? Modern patients sign informed consent forms before anesthesia, but they still place their trust in hands guided by centuries of trial, error, and innovation. Consider the 21st century frontier of awake craniotomies, where surgeons remove brain tumors while the patient is conscious to monitor language and motor function in real time. The procedure itself traces back to medieval trepanation, but it differs in precision, hygiene, and patient comfort. Yet the underlying principle remains: open the skull to let hope and healing in. As we reflect on medieval surgery's cures worse than the disease, we see a journey from superstition and spectacle toward science and empathy. The horrors of uncontrolled bleeding, agonizing pain, and rampant infection forced generations of physicians to question, experiment, and ultimately transform medicine into a discipline grounded in compassion and evidence. So next time you read about a daring surgical breakthrough or watch a tense operating room drama, remember the courage and cruelty of those who came before. They bore the wounds of ignorance so that we might reap the benefits of knowledge. Their legacy lives on in every sterile glove, every anesthetic drip, and every life restored against odds that once seemed insurmountable.